right after the cookies. The irony was not lost on me. So I will be talking about obesity today, and as I said yesterday during the diabetes talk, there is quite an overlap now in the diabetes world in the obesity space. So some of the slides I had in this deck, in case there are people here today that were not here yesterday, but I'll zip through them pretty quickly. Here are my disclosures. So today we're going to talk about obesity prevalence and complications. We're going to talk about realistic weight loss goals. As it turns out, the majority of patients as well as providers may be aiming a little bit high than what is realistic. And then we're going to talk about a 5-pillar approach to helping patients lose weight. So what is obesity? Obesity is defined as abnormal or excessive fat accumulation that may impair health. Right now, we define it by a BMI. That's really an insurance-based type of thing. But the truth is there are other markers that are much better than BMI. A frail older person with low muscle mass might have a normal BMI, but might actually have obesity or complications related to obesity. Similarly, a really fit person with a lot of muscle mass might be in the obese range and not have any metabolic complications. So while it's categorized on BMI, I think over the years that will be falling out of favor while we focus on other markers. And you can see BMI is even further subdivided with different classes of obesity, class 3 being BMI of 40 or above. Other forms of staging for obesity would be the Edmonton obesity stage, which is really looking at whether or not people have complications related to their weight, not just BMI-based, so looking at things like physical symptoms, psychological symptoms, functional limitations. ACE, an endocrinology organization, focuses on this complication-centric model. Instead of obesity, they're really trying to call it ABCD. They're promoting this acronym, which is adiposity-based chronic disease, because patients don't like the word obesity. And really, we don't care as much about a BMI. It's just a surrogate marker. We want to know how their fat accumulation is actually affecting their health and their metabolic state. So ACE, you can actually see down to a BMI even below 25 in certain ethnic populations if they have central adiposity, central weight gain, increased abdominal circumference, increased percent body fat, so things like BIA analysis, body impedance type analysis, to look at other forms of markers aside from just a weight and a height. Obesity prevalence, this was in 2018, was 42.4% in adults in the US. Just as Julio was talking about yesterday, how more people were drinking during the COVID pandemic, more people were also eating. We had constant access to our kitchens, we were stressed, we were at home all the time, and we were just eating more. So there's been a very significant amount of weight gain related to the COVID pandemic. We know that obesity is a big deal because we know it's correlated, at least, with all-cause mortality by BMI. There's this J-shaped curve. As your BMI gets low, you can also see increased mortality, and that's probably more correlative than causative because people who are sick tend to lose weight. Lots of medical complications, hundreds of medical complications related to obesity, but this slide just has some of the top ones. So heart disease, we know about cardiovascular. We talked yesterday about non-alcoholic fatty liver disease, or MASLD, or MASH, whatever we're calling it now. Cancer, gyne issues, infertility, which is why weight loss can help so much with fertility. But there are a lot of other complications of obesity that we're not talking about that I want to make sure that I discuss today as somebody who tries to advocate for persons with obesity. Things like dementia, depression, and mood disorders, especially women. Women are really impacted by their weight, and it can affect their mood pretty profoundly. Men, usually it requires a much higher body weight before they start to feel more depressed about their weight. Sexual dysfunction, we know that weight affects your hormones, your binding globulins, your sex hormones, and can cause low testosterone in men or other sexual issues. We know there are personal and social costs, professional and employment costs. There's a lot of discrimination. It's one of the few remaining things where we are still discriminating against. And it's funny when you watch old movies, you can really see it, but it's always like the evil person, the lazy person, the sloppy person is always like someone who is 100 or 200 pounds overweight. It's just these depictions, which are definitely getting better over time. But these are some of the pictures you'll see in articles, news articles talking about obesity, as though people who suffer from obesity have no willpower, no motivation, they're lazy, they sit and eat McDonald's on their couch, or they can't button their clothes. In the last few weeks, I don't know, Facebook and Instagram have been targeting me, like they know I was going to be talking about this, and I'm just getting all of these articles about celebrities, and this article, which came from The Economist, and it was all about how women's weight affects their wage. And there was another article that said, can being thinner make women richer? And it says, I don't know if you can see it, for an obese woman, not a woman with obesity, would be person first language, losing weight could boost her salary as much as obtaining a master's degree. I didn't know that, but I'm not surprised. I just think it's very interesting to see how much we might even have bias that we're not even aware of in the workplace and social situations. So weight bias and discrimination is this belief, these negative attitudes, beliefs, judgments, stereotypes against people because of their weight, where they're seen as individuals who are lazy or unmotivated. And my goal is to break that notion so that we can have more compassion, we can have more sympathy, more empathy for our patients, but also for ourselves, because we're pretty hard on ourselves too. We're not exempt from struggling with things like diabetes and obesity and alcohol use. So what I want to tell you guys is it's really complex, it's a chronic disease, it's not easily treated by eat less and move more, and it has many different causes and progressive by nature. So in some ways, the first half of my talk is like the most depressing thing ever. What are the limitations in primary care in treating obesity? And there are a ton of them, but there's lack of resources. A lot of us trained when obesity wasn't a field, right? Like, we didn't have obesity medications. We treated the complications of obesity, but we didn't use weight loss medications. We didn't use bariatric surgery as a tool beyond just for weight loss. So just this knowledge base can be, an issue. Not having time. I know when patients come see you, like, you have 50 things, and probably at the top of their list might not be the plan to lose weight, or maybe that's what they want to talk to you about, and you want to make sure they're up to date on all of their cancer screening. Lack of comfort discussing weight. Sometimes providers feel like if they're overweight, they're hypocritical trying to talk about weight with patients. Sometimes if they're thin and have never struggled with weight, they feel hypocritical trying to educate people on this, like they don't understand. So just discomfort, the way you bring it up, can also affect patients. Unrealistic weight loss goals and timelines, and something that I feel pretty passionately about is the lack of use of medications in bariatric surgery. As much as I would love to believe that we can lose weight holistically, significant amount of weight loss, and maintain that weight loss, all of the studies is just showing us that that is so unlikely to happen. People think that medications and surgery are a crutch or a patient failure or something temporary. I often have patients say things like, I should be able to do this on my own. I want to do it naturally. Weight loss surgery is the easy way out. Surgery is not the easy way out at all. The things that they have to do, the changes they have to make for bariatric surgery is huge. Like no alcohol, no caffeine, no NSAIDs, no coffee, like huge changes, protein shakes, gradual dietary progression. Again, I was being targeted by Instagram this week, and they know that I love pop culture. So this showed up. This is Heidi Montag, for those of you who watched The Hills, or Laguna Beach before that. And it was how I lost 22 pounds without Ozempic, okay? This was the article, and I was like, I don't know why, but I couldn't believe that Ozempic made it to the front page. But it makes sense, because everyone is obsessed with Ozempic right now, right? Julio was talking about Ozempic butt and Ozempic face, like it's everywhere. I'm going to tell you more about this article later, but I was just so amused that this came out, but I was also a little bit enraged because it implied that there's something wrong with using a medication or having surgery. We tend to see these types of images, these unrealistic weight loss goals of before and after, where the before is like so sloppy, the after is like so fit, 12-pack, I don't even know, like Barbie-like proportions. Every year around New Year's, you'll see People magazine comes out with their half their size article, where they talk about usually two women who have lost half of their size, clothing size, and at the bottom it says no surgery, no gimmicks, implying that bariatric surgery, weight loss medications, they're a gimmick, they're a crutch, and if you had enough willpower, you could do it on your own organically, which unfortunately doesn't really seem to be the case. So how much weight do we actually need to lose to help reduce complications? Julio was talking yesterday about MASL being over 10%, but somewhere in the 5 to 10% range of your total body weight for someone who's 200 pounds, 10% would be 20 pounds. Some disease states require higher amounts. Sleep apnea seems to be a bit more refractory as well, and often with certain diseases, the higher amounts, the better. So according to the CDC, you can tell patients, good news is no matter what your weight loss goal is, even a modest weight loss like 5 to 10% of your total body weight is likely to produce health benefits. I tried to come up with a better before and after picture, but I've always kept in the third elbow to remind myself that this was not a before and an after picture. This was the before, during, and then there was another after where it looked like she had lost 100 pounds. Even from here to here, it looks like more than 5 to 10% total body weight loss. So still probably not realistic, but this was the best that I could do. Why is it so hard to lose weight and keep it off? Industrialization, our food system, ultra-processed, highly palatable, almost addictive foods, most foods being eaten in restaurants, low quality, higher cost for higher quality food, occupations being sedentary, driving everywhere. So yes, we eat more and we move less. So hypothetically, if you ate less and moved more, you could just lose weight, right? So one of the fathers of obesity medicine was, I believe, a psychiatrist named Dr. Stunkard, who in the 1950s started trying to research why it was so hard to lose weight. And he reviewed his data along with his partner and found most obese persons will not stay in treatment, most will not lose weight, and of those who do lose weight, most will regain it. And this was how many years ago? 60, 65 years ago? Not that much has changed, unfortunately, which is so depressing, but this was a very astute observation at a time when obesity wasn't even as rampant as it is now. So why can't you lose weight easily by cutting calories, right? Are there confounders, calories in versus calories out? So maybe certain plans, maybe certain sources of calories, patients will respond to them better. Maybe some do better on keto, some do better low fat, some do better with a whole food plant-based plan. Maybe certain foods affect satiety or hunger more, like maybe protein makes people feel more full, whereas low-fat diets, they're hungry and overall eat more calories per day. We talked about the carbohydrate insulin model of obesity yesterday, where high carbohydrate foods increase insulin levels, promotes fat storage. Maybe that has something to do with it, these spikes. Artificial sweeteners or zero-calorie foods, there's more and more data that things like saccharin and sucralose might actually change your gut flora or cause this acute insulin resistance or make you hungrier. So there is some data suggesting that even though there's 0 calories, we might be causing metabolic disease anyway. Other interacting medications, and then menopause, which I'm like terrified for because I think half my patient population is women in their late 40s and early 50s who the only reason they've gained weight is menopause. This low estrogen state promotes loss of lean body mass, so your metabolic rate goes down. Decrease in estrogen also causes insulin resistance, and what do we know when we have insulin resistance? It promotes fat storage, especially central fat storage. So now women develop this pregnant abdomen. They're all complaining they look like they're pregnant. They never used to gain weight in their stomachs, and it's really frustrating. So, conclusion, body fights very hard to lose weight. It will do everything it can to make sure you don't lose weight. So for every kilogram or 2.2 pounds of weight loss, your metabolism is lower by 30 calories per day. 30 doesn't sound like a lot, but let's just say you lose 20 pounds or 10 kilos. Now you burn 300 calories less per day, but even worse, your appetite goes up by 100 calories per day. So that's 1,000 calories per day more that you want to eat to feel satiated after losing 20 pounds, okay? You will see in studies, or even historically, and maybe in yourself or in your patients, early on people do really well. They start keto, they start Jenny Craig, they do Weight Watchers, they have a few really great months, OptiFast, they lose 20, 30, 40, 50 pounds. Then eventually there's a plateau and then a progressive weight regain. And you can see at the 5-year mark here, it's about 80% of weight regained, but I actually think usually it's even more than this. And sometimes it's gradual and patients are like, I'm still eating the same, I don't know why I'm gaining weight. But I find a lot of times it's like instantaneous. I went on vacation, I never could get back on track. They think there's something wrong with their willpower, but it's not. It's a physiologic response to caloric deprivation. This is a study that was done years ago that showed with whether you did behavioral modifications, a very low-calorie diet, or both combined, you could lose weight in the intro period. But 5 years after treatment, all the weight came back, if not bonus. So it looks like people lose motivation or willpower, but there's really strong internal forces that increase their drive to eat more. So I showed changes in ghrelin, that's the super strong appetite hormone made in the stomach, secreted by the stomach. And you can see after a period of weight loss, people's ghrelin levels are so much higher than they used to be. So a similar meal will not make them feel as full as it used to. They are just so much hungrier. Also, there's a decrease in energy expenditure. And this is subtracting how much you would have predicted, because when you have a lower body mass, you don't need to expend as much energy, right? But this is beyond. So with 20% loss, you can see even beyond what you would have expected for that weight. Years ago, there was this sensational Biggest Loser studies that got published in a medical journal. And it was really interesting and really depressing because these were contestants, for those of you not familiar, where they go to this ranch, they work out with personal trainers, Jillian Michaels, Bob Harper, they used to be the trainers, and they lose a ton of weight, and it's a competition to see who can lose the most amount of weight, and then they win money. Isn't that fun? So it was kind of nice because they were evaluated by doctors before and after, and they did a study 6 years after the competition completed with 14 of the contestants, and they basically saw, so right after the biggest loser show ended, so that 30 weeks, you can see how much their resting metabolic rate had decreased from baseline. And you can see at 6 years, it didn't really improve. So the decrease in metabolic rate stayed the same, which maybe makes you think, oh, that's great. But what you're missing is the fact that almost all of these patients had regained almost all of their weight. So now they were back to their starting weight, but burning even less calories than they were before they lost the weight. They were worse off than they were before they had gone on the show. You can see here, this is metabolic adaptation, so that's the residual decrease in resting metabolic rate that is accounting for the changes in body composition and age that you would expect over time because our resting metabolic rate decreases over time, and it actually got worse. And the people who lost the most weight were the people who are at even a greater metabolic disadvantage. So is overeating somehow adaptive? I love these two examples. This is a picture of the Donner Party. Do you guys remember this? Oh yeah, I see a lot. Okay, so this was settlers that went from the East Coast to the West Coast, and they got trapped in the snow near Lake Tahoe, and they were starving. And I know you guys think what I'm going to talk about is cannibalism, but that's not what I'm going to talk about. But apparently there was some cannibalism activity, and I don't judge because when you are starving, you do crazy things, okay? But what was so interesting to me is that they knew about refeeding syndrome, and when they were rescued, the survivors were rescued, they were supposed to be very slowly reintroduced to food, so they didn't die from refeeding syndrome, but some of the people that were rescued died after rescue because they could not control themselves. And there's the story of one, I think a teenage boy who was found outside of the camp with food shoved in his pockets. In the middle of the night, he basically overate himself to death because he was so hungry and could not stop himself. During World War II, there were protesters, men who did not want to go fight in the war. So instead they said, okay, then we are gonna admit you to basically a hospital ward and we're gonna starve you for a few months. And we are gonna learn about famine and prisoners of war and survivors, Holocaust survivors, all of this stuff so we can understand what happens. These are two gentlemen. This is not a before and after. These are both afters. So they starved these men, and there's so many psychology studies that are published on these patients. This is, somehow they got IRB approval for this. And they were obsessed with food. They watched cooking shows on TV. They were angry with each other if they didn't finish their food. Some of them, when they did get access to food, they were binge eating. They would eat to the point that they would vomit. Some of the participants went on to have careers as professional chefs. They were literally obsessed with food. So the theory is, and I think it's pretty obvious, that after a perceived or true period of famine, your body responds in a way to try to survive, which it would have done 1,000 years ago, to protect yourself from future starvation. And I tell patients this, and honestly, it relieves a burden from them because they think there's something wrong with them, but telling them, you are perfect. Your environment is not perfect. You evolved in a different environment. So here are the 5 pillars of weight loss. Let's be a little more optimistic. Can we actually lose weight? And of course we can, right? We have success stories. I saw Oprah's special, It's possible. First, rule out secondary causes of obesity. So number 1 is a period of weight loss. Often I get referrals, patient gained 50 pounds in a year, can't figure it out. Ruled out sleep apnea, ruled out PCOS, no thyroid disease, did a Cushing's test, did a dexapression, 24-hour cortisol in the urine. I'm like, great, totally full workup. Tell me, before you gained 50 pounds, what was your weight history like? Had you lost weight? Oh yeah, I lost 30 pounds doing OptiFast before my wedding. Well, there you go. That's it. Your body was compensating, metabolic adaptation. Your body was afraid it was gonna starve to death and it wanted to regain the weight, and that's it. So we can do this whole secondary workup, but really getting the history is important. Look for medications that might impact weight, okay? So here's some medications that might increase weight. I just want you to have this table, and some alternatives that are either weight neutral or can promote weight loss. And I put in bold some that I use sometimes off-label, so not as an FDA-approved medication for weight loss necessarily. The Endocrine Society says don't use these off-label unless you are backed by research and have a lot of comfort in doing so from a medical legal standpoint, but I do it anyway. I feel comfortable doing it. So I just put these. I don't use SGLT2 inhibitors. I see a lot of primary care doctors using those off-label for weight loss. Not good weight loss medications because you're just losing calories in the urine, but eventually your body realizes you're losing weight and it adapts. So usually the weight loss is 5 to 7 pounds and then it stops because all these mechanisms are still there. Diet we talked about ad nauseum yesterday. So there is no one perfect plan, just as a reminder. The emphasis should be on non-starchy vegetables, minimizing added sugar and refined grains, choosing whole foods over highly processed foods. My 3 S's being something safe, simple, and sustainable. Here were the recommendations that are evidence-based. Most plans are evidence-based. Weight Watchers has published studies on the benefits of Weight Watchers. So there is no one perfect plan for everyone. So please, let's get out of that mindset. And then have resources that you can give to patients, and then that clothing label that I hate that says one size fits all, cross it off, said most, which I just thought was so discriminatory. But in the 90s, people could do whatever they wanted. Exercise. ACE. So yesterday I talked about the ADA, the American Diabetes Association, recommendations for exercise. ACE, the endocrine organization, just says increasing activity burns calories. It can augment weight loss. It can help things like lowering blood pressure, helping with sleep, helping with mood, better heart health. Start with shorter duration, work up over time, ideally 150 minutes per week of moderate intensity activity and at least 2 days per week of muscle strengthening activity. Muscle is so important, especially with these medications where people can lose weight without exercising and are losing 20, 30, 40% of their weight from lean body mass, which is so essential, especially as we're getting older. So really, if I had to choose for patients, I tell them weight-bearing activity, especially if they're on a GLP-1 medication and rapidly losing weight. Behavioral. So to me, this is behavioral interventions, which includes things like self-monitoring, group support, frequent high-intensity visits. But it also, to me, includes ruling out eating disorders and mood disorders. So things like binge eating disorder, bulimia, night eating disorder. So this is when people are eating most of their calories in the evening hours and or waking up during the night to eat. And this is when they're awake. This is not sleep eating. This is awake. Reward eating, depression, anxiety, other things that are complicating it. I always recommend referring to an eating disorder specialist for CBT or consider a weight management referral. I have lists of psychiatrists, psychologists who are experts in this field. I am passionate about binge eating disorder. I think it's very underdiagnosed. So I just have a few slides about that. But essentially, it's defined as consuming a larger than normal amount of food while feeling a lack of control with respect to the ability to stop eating. These are episodes that are distressing. This is not I went out with my girlfriends and had 2 margaritas and 500 chips with salsa. This is like I could not control myself. I sat down, I ate quickly. Sometimes it's in secret. It's associated with shame, embarrassment, hiding food from other people. Way more common than we think. The most common eating disorder that's out there, somewhere between 2 to 3.5% of the population, maybe as high as 20% of people with diabetes, and up to 40% of those seeking weight loss surgery, 30% of those coming to weight loss program. I would say probably 20% of my patients I do diagnose with binge eating disorder. Some are mild. It's a spectrum, right? So some are binge eating tendencies, but maybe don't qualify for the diagnosis of binge eating disorder. It's associated with worsened metabolic disease, inflammation, poor mental health, other substance abuse, and it's an exquisitely distressing disease that we can help treat. It's associated with constant preoccupation regarding food, their body weight, weight loss, shame, guilt, embarrassment. They think there's something wrong with them, that they can't stick to the plan, they have no willpower, and if they had more willpower, were better people, they could. The BED7 is a screening tool that I like to use, but there's lots of great screening tools out there. Just asked in the last 3 months, have you had any episodes of excessive overeating? Our intake form says, do you have concerns that you may have binge eating? And I have so many people check off yes and not have it, but that's what makes it a good sensitive question, right? But so many people that actually do have it. The DSM has criteria, so I put this here for you, but it has very specific criteria for what is considered binge eating disorder. So if someone flags positive, and I'm asking questions, I will literally say, describe an episode to me, and then I'll say, here's the DSM criteria, blah, 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 blah. Does this sound like you? And then how many times per week? It can go from mild to extreme. Can you imagine 2 episodes per day of these awful binge eating episodes? That would be extreme. There's treatment for it, there's behavioral therapy, there's dietary interventions, there's medications. As medical providers, I use a lot of medications, often off-label for binge eating disorder. There's only one that's FDA approved for binge eating disorder, which is Vyvanse or lisdexamfetamine, which is hard to get and it's super controlled, so it's not my favorite. It can also have stimulating side effects, increased blood pressure, heart rate. So just remind patients they're not abnormal. This is not a lack of willpower or laziness. It's not your fault. There's a basis for this. There's a basis for all causes of obesity, and I think just that compassion can be so helpful for patients and yourself. Let's talk about medications, which is probably what you guys are most excited to learn about, although you guys have been learning about them all week, right? You had the pharmacist talking, you had Julio talking, cardiology. There's so many things out there that are now overlapping, which is really exciting. So the FDA says it's okay to use a weight loss medication if you have a BMI of 27 or above with a comorbid weight-related condition or a BMI above 30. Do I ever use it for a lower BMI? Yes. Asian, Indian background, central adiposity, increased body fat. abdominal circumference, you can tell. Or even if someone just lost 100 pounds and now they're regaining the weight, it's maintenance of weight loss too, right? Their starting BMI was high, just like someone who has hypertension on medication does no longer have hypertension once their blood pressure is better controlled on the medication. The medications can augment weight loss and improve adherence with behavioral interventions. So they don't go on vacation, they don't have their wedding and then fall apart and be unable to get back on track. It helps them be a little bit more moderate, not black and white mentality where they're either perfectly on track losing weight or they're totally off track gaining weight. You're supposed to evaluate for response. Every label is a little bit different, but in general, a medication should result in about 5% of body weight at the 3-month mark. If you're titrating up slower, you might evaluate at 4 months. If they're maintaining weight loss and they find benefit, that to me is a success. You could try to argue it, although that's not always what insurance wants to hear. What medications are out there? I put brand names and generics. I tried to be as inclusive as possible. We are all excited about these injectables, but there's some issues with them right now, so I don't want you to forget that there are other great medications out there that are affordable, that are in stock at pharmacies, and are approved for long-term use. So phentermine, diethylpropion, phendimetrazine are 3 kind of stimulant appetite suppressants. Technically, phentermine not approved for long-term use, but it's state dependent on if you can use it for more than 3 months. There is no data that says using it beyond 3 months is a problem, just no one paid to do those studies because back when phentermine was approved, people thought you could lose weight for 3 or 6 months and then stop whatever you were doing and somehow magically maintain that weight loss. We know that's not true. Phentermine is one of the components of Qsymia, which is phentermine in combination with topiramate, and that has been studied long-term and is approved for long-term use. So again, off-label long-term use in the state of California is totally fine. You don't need to do an interruption in medication. There's Qsymia, combination of phentermine and topiramate, which is nice because people struggle at night, and phentermine is stimulating, and you don't want to be stimulated at night, right? But that's when nothing good happens. Remember last night, yesterday, no broccoli while they're watching Netflix? So it's nice to have topiramate on board because if anything, it's sedating, but it can help with those evening cravings after dinner. There's Contrave, naltrexone, bupropion, which is a combination of an antidepressant with this opioid antagonist, which can help with reward eating, cravings, emotional eating. There's the lipase inhibitors that I never use, but sometimes insurance is now requiring that patients fail that therapy before they can get better medications. I try to argue that they all have low vitamin D, because that's associated with obesity, and that this blocks vitamin D absorption as my reasoning for why they can't be on this medication. And then we have the injectable GLPs, the 3 that are approved for weight loss. Remember, not Ozempic, not Mounjaro, not Victoza, but these 3 are FDA approved for weight loss. We lost Belviq during the COVID pandemic, some cancer concerns, not going to come back. Plenity, which is technically a device and not a medication, was $100 per month and didn't do all that much and is not doing all that well, so it will be leaving too, and then so many more are coming. So this was published, I think, in 2015. And it was basically a comparative table from the ADA that was looking at the different efficacy of the existing weight loss medications. And this is Qsymia, Saxenda, Contrave, Belviq, Orlistat, and phentermine. This is pretty low here, but it's only a 24-week study. This was all done at 1 year. These are placebo-subtracted, so trying to take out the placebo group to understand what weight loss was just attributed to lifestyle interventions. And you can see somewhere in the 5 to 10% range, which was good because that helps with health, right? And this was great. So what's the hype? Why are we so excited about all of these medications now for weight loss, right? Is it because the New England Journal of Medicine published some amazing study 5 years ago about the weight loss results from Wegovy? Semaglutide 2.4. No, it's because of Hollywood. Some of this is totally Hollywood related, and it's partly good, but also partly insane that it didn't pick up. Like, I was the bad guy for suggesting patients go on medication before. Now I'm the bad guy for suggesting bariatric surgery. But now they're coming to me like, I want Ozempic. Okay, can I get Wegovy? As though they're 2 totally different things. Like all this confusion. My friend's sister is taking blah, blah, blah. She's lost 1 million pounds. Anyways, so Elon Musk tweeted a few years ago, this was in 2022, that he had lost weight through fasting, and then he added, and Wegovy. Then other celebrities have either come out as openly having taken it. Apparently Chelsea Handler accidentally got it from some type of med spa. But there's, people are talking about the Kardashians and all these people. Kelly Osbourne had a statement. This is the least evidence-based slide I've ever made. I couldn't fit everything onto one slide, but Dateline had an hour-long episode recently, not even recently, like a year ago, talking about these medications where doctors were interviewed and people were saying it was basically like a 1-hour promotion. Fox News, this is Jillian Michaels again, you guys remember from The Biggest Loser. She should have learned from The Biggest Loser study. But here, she is all into natural treatment, and she is against these weight loss medications, and she's going on and talking about them on podcasts and TV. But I'm just so amused because it says doctors raise the alarm. She is not a doctor, okay? Maybe she has a PhD. I shouldn't say that, but she's not a medical doctor. Tracy Morgan, this is all of this bottom things just popped up on my news feed in the past 2 weeks. Tracy Morgan says he gained 40 pounds on Ozempic after learning to out-eat the weight loss drug. This is an advertisement for a bar called Supergut, Discover Life with Wozempic, and it says natural GLP booster, and you can't see this, but down below it says, don't ask your doctor if Wozempic is right for you because it definitely is. I don't even know how this is legal to use. Like, there's no way this is legal, but people are going crazy. People magazine, Ozempic babies are on the rise. It's become mainstream culture, right? Like, this is insanity. Women getting pregnant while taking it, and it says a lot of times it's unintentional, but like I talked about yesterday, sometimes it is intentional. Oprah had her special recently, Shame, Blame, and the Weight Loss Revolution, where she talked about how people have been mocking her for her weight and judging her for her weight, and really, like, you know, she had physicians, well-respected physicians, talking about really the reason behind it and these medications, and it was thoughtful, but it didn't talk about a lot of the problems with these medications, so I'd like to talk more about those things. Let's get back to Heidi. Okay, so she's on the cover. I was pissed about this. I don't know why I was like outraged. I like posted it in one of the obesity Facebook groups for providers, and I was like, you guys, like, this is on the cover of Us Weekly. Before this conference, I looked up the actual article, and you're not gonna believe this. It's a before and after of Heidi, weight loss, sponsored by Hydroxycut. So here she is, how I lost it without Ozempic, but she used Hydroxycut, an over-the-counter, non-FDA regulated weight loss supplement. It just screams such hypocrisy. I'm putting that in my slides because I was so angry, okay? Because implying you can do it without Ozempic, I did it with Hydroxycut. Come on. So we talked about GLPs, what they are, GIP, gastric inhibitory peptide, how they're secreted by the gut in response to consumed nutrients, and then they travel downstream and have all these other wonderful effects. So we have semaglutide, we have liraglutide, which are just GLP, we have tirzepatide, which is called the twincretin, which activates both GIP and GLP receptors, which causes this wonderful synergistic effect. They have downstream effects on other organ systems, which we talked about yesterday, telling the brain you're not as hungry, maybe not as thirsty, protecting the heart, wonderful things with those cardiovascular outcomes that we talked about, protecting the brain potentially, dementia, lowering the desire for alcohol, and then we know that they're traditionally affecting the pancreas as diabetes medications and the liver, which was very exciting. Again, here's the table of all of the medications when they were first approved, how you titrate them, because remember, GI side effects can be quite pervasive and difficult, so you want to start low and work up slowly. So this is kind of the maximum rate at which you want to increase, but you can definitely go slower if tolerated. The ones highlighted are the weight loss medications. All the other ones are approved for diabetes only. So yesterday we talked about how much weight loss patients with diabetes had in response to this medication, and it wasn't the exciting weight loss that we all think of when we think of these medications. That was seen in the obesity trials, right? Not in patients with diabetes. They always lose less weight in clinical trials for a variety of reasons. So here's semaglutide Wegovy 2.4 milligram, and you can see that the weight loss beyond a year was 16%, which is wonderful. Before we looked at 5 to 10%, now we had 16%. Is this equivalent to bariatric surgery? No, but it's still wonderful weight loss without surgery. You can see, though, that while so many people, so 92% of the people that stayed on the treatment lost at least 5% of their body weight, that means 7% of people did not. So we're going to start looking at tables like this. You can even see people who tolerated the medication, 35% of them lost more than 20% of their body weight. We're going to start looking at these tables rather than just the averages because it tells us more about response. There are some people who respond really well to medications and some that don't respond at all. Of course, in the last few weeks, there's some other really exciting things. So in the fall of last year, this was published in the New England Journal of Medicine, Semaglutide and Cardiovascular Outcomes. And what was really cool about this is this was not a cardiovascular outcome trial designed for patients with diabetes. This was a study in the obesity medication for patients that did not have diabetes, but had a history of underlying cardiovascular disease, such as heart disease, known heart disease, or prior stroke, or peripheral arterial disease. with low ABI requiring revascularization or amputation. And you can see the endpoints, and this is in months since randomization, was so much better in the semaglutide group than it was in the placebo group. So March 8th, less than a month ago, semaglutide got FDA approved to reduce the risk of cardiovascular death, heart attack, and stroke in adults with heart disease with obesity overweight. This is groundbreaking. No weight loss medication has ever gotten approved to help with heart disease. If anything, they've been pulled from the market because of risk of heart problems like fen-phen and sibutramine or Meridia, which is why the FDA would not approve any weight loss medication for 1,000,000 years, which is why most of the recent medications are just reformulations of already FDA-approved medications like Qsymia, Contrave, and the GLP-1 agonists. So that's really exciting. This is amazing. What else is amazing? A week and a half ago, I couldn't stop making slides, you guys. It wouldn't rest. Medicare is going to cover Wegovy for patients with heart disease. Do we know yet what exactly that means? What criteria for heart disease? Does that mean dyslipidemia, hypertension? No. That was not what was in the SELECT trial that I just talked about. This is people with history of stroke, history of MI, amputations. Medicare excludes weight loss medications. No Medicare plan covers a weight loss medication. If you have a Medicare patient and you're prescribing them Zepbound or Wegovy, they're going to be told it's $1,300 from the pharmacy, okay? Don't even try. Don't try to get a prior authorization. The odds of it are low. But this is opening a new door. And most insurance companies follow CMS regulations, right? So hopefully this will start to trickle down into commercial insurance plans. And that would be amazing. Now, this is a very specific subset of patients, but if Medicare is going to start looking at these medications as not just weight loss medications, but medications that improve health, morbidity, mortality, cost, I'm sure that's very important to them, this is going to change everything. So I think over the next few years, we are going to see such a shift in the culture of treating obesity and its related complications. Now we have tirzepatide. So these are patients without diabetes who lose more, 22%. Are we at bariatric surgery range yet? No. But we're getting there, which is exciting. And what's amazing is in the highest dose, so those who could tolerate the 15 milligram Zepbound, 40% of them lost 25% of their body weight. So for some of them, this was kind of getting to gastric sleeve equivalency, right? And they continue the medication long term. As a reminder, the ADA has a table that talks about the risks, the benefits, contraindications in a really nice, concise table, so you have it there. We talked about how to prescribe it, what to do with the needles, the pens, where to inject it, which pen needles you want to prescribe for your patients, right? This one, not this one, because we are kind, compassionate people. Don't use them in people who have allergy or hypersensitivity to the medications, history of pancreatitis, aside from that gallstone pancreatitis where the stone is gone and the gallbladder is gone. Family or personal history of medullary thyroid cancer, rare disease, not very common, not really a concern in humans, but of course discuss it and document. Not studied in type 1 diabetes or pregnancy, and caution in gastroparesis. We talked about side effects, how to eat and drink to minimize those. So light, small meals, low in fat, not with a lot of alcohol or liquids, hydration between meals, not with meals. Liquids tend to be better tolerated as it can be with people with gastroparesis. So sometimes I tell people, if you are laying down flat and having reflux, have a protein shake for dinner. Have a light vegetable soup for dinner because the liquids potentially might be absorbed better than solids and might have less GI issues. But you will have patients who overeat or eat normally and vomit. So be aware of that. Increased heart rate can be a concern. We talked about the effects on mood or energy, potential hypoglycemia if patients would have diabetes. Dehydration is always my biggest concern. We also talked about no direct causal relationship for pancreatitis or pancreatic cancer, what the FDA says about not having a correlation, but I still always have the conversation with patients who have seen a loved one pass away from pancreatic cancer because it's a really brutal, awful condition, and I think they are deserving of knowing what the data shows and what the data doesn't show. So pitfalls of the GLPs. Tolerability. Some patients take 0.25 of semaglutide and are vomiting for weeks. Some patients feel nothing, and they can ramp up to 2.4 faster than once, going up every 4 weeks. It's so strange, and it's not predictable, but some patients just can't tolerate and others can. We talked about how there's some non-responders, which with these more potent medications, we are having less and less non-responders. The cost, dear Lord, this cost. And then insurance coverage. Insurance is getting worse with coverage. The excitement is going up, the coverage is going down, and for whatever reason, I feel like patients are blaming me for this problem because the insurance company is telling them, oh, we will cover it if your doctor does a prior auth. Oh, your doctor just needs to call this phone number and do a peer-to-peer appeal, and then it will be covered. And I'm just like, no, I'm not doing it. I've tried doing it, I've failed miserably, and I'm just not doing it anymore. You can take it up with your insurance company, with your HR, and we can come up with more affordable options, but I can't call in an appeal for every single patient who's getting insurance denial because it's almost everyone now is getting insurance denials. It used to be 50% of companies in San Diego were covering weight loss medication. It's probably in the 30 to 40% range now. You need to use them long term, so this is not, if you can afford it for 6 months, let's do it, right? This is a marathon, not a sprint. Obesity is a chronic progressive medical condition. We're not looking for a short-term fix. Here's the cash cost for diabetes medications, but look at the weight loss medications. I went on GoodRx. You want to pay for Wegovy? The cheapest in San Diego was $1,300 per month for the rest of your life. What happens if you stop the medication? I don't know why, but everybody believes that they are going to be that exception who can lose weight naturally and keep it off, even though the studies all show us that that's not the case. Well, once I have these good habits in place, once I've lost the weight, I've been able to maintain my weight in the past. I'll be able to lose 50 pounds and keep it off. That is great, and I'm happy to support you in trying, but unfortunately, that's not what the evidence shows us, and as soon as people start to regain weight, you need to intervene, because as they regain the weight, we talked about the Biggest Loser study, they are worse off than they were before they lost the weight, okay? So this was studied in the step 4 done by Novo, looking at semaglutide for weight loss, so Wegovy, and you can see they randomized everybody at the 20-week mark. So everyone got Wegovy for 20 weeks. They did a ramp up. Then they blindly, placebo-controlled, randomized them to this placebo group or to continue semaglutide. And you can see, even though they're in a research study, coming in for weigh-ins, working with a dietitian, trying to maintain their weight loss, and thinking they might be getting the medication, the weight is still coming back. And I would argue that if this were to be extended, it probably would come back to where they were when they started, unfortunately. And now they've replaced a large percentage of their muscle with fat tissue. So they are way worse off than they were before the weight loss. This was the SURMOUNT trial, so this was with Zepbound, so tirzepatide for obesity, SURMOUNT-4, and I literally have printouts of these studies in my office, and I show it to patients. That's great, but let's look at what the data shows us. I'm a very visual person. I want them to be able to see it so they can understand what it really looks like, okay? And you can see weight regain when randomized to placebo. The logistics of prescribing weight loss medications have gotten so depressing, okay? And I feel like that's what most people who have been talking to me at this conference have been talking to me about. Like, these medications are great. How do I get them covered by insurance? What's your secret? What's your trick? A lot of people within the Scripps system refer. We have a weight management department. They try to get coverage for medications. They're denied. And they say, go see weight management. See if they have some trick to get this medication for you. These are not restricted to endocrinologists or weight management clinics. There is nothing creative that I'm going to do, and I'm definitely not calling in appeals for all of these things. So we are all just so stuck with these amazing medications out there that we can't get, either because of a shortage or because of insurance coverage. The FDA approval dictates insurance coverage. So so I said BMI 27 or above with comorbid condition or BMI 30 or above, but now you'll start to see some insurance companies are requiring bariatric surgery level obesity in order to cover weight loss medications. And they're saying, we will cover a weight loss medication for you only if you're using it in place of bariatric surgery, because their cost analysis found that that was more optimal for them, which is kind of messed up. And actually at Scripps, that's what the Scripps EPO plan, which is kind of a PPO plan, is now doing. You either have to have pre-diabetes or diabetes, which makes no sense to me because then they would just get the diabetes version, or you have to qualify for bariatric surgery but be taking weight loss medication in place of bariatric surgery. Now remember, what they're FDA approved for. If you have a patient who has obesity, suffers from obesity, and you prescribe Ozempic, it's not FDA approved for obesity. It's FDA approved for type 2 diabetes, denied. Some people were flying under the radar, but insurance companies are catching on. They're no longer doing that. Now they're requiring, almost in January, almost every insurance company is requiring a prior auth, even for people with diabetes for these medications, because the off-label use has been astronomical. And why should they pay for something they don't have to pay for? Semaglutide 2.4 under Wegovy, not approved for diabetes. You want to get one of the diabetes medications covered. Off-label coverage getting harder. I am not a fan of these coupon programs and using medication samples. I often say they are a bridge to nowhere. And then patients have to walk back on the bridge, completely backtracking. And there is no more disgruntled a patient than someone whose life was changed by a 6-month coupon for Wegovy for $25 a month, only to then have it go up to $1,300 per month and to tell them, if you want to continue it, you have to pay. You're out of luck. There's nothing else you can do. You can try going to Mexico. Don't do that. But I am really close to the border. And I do have patients that do that. So I'm just not a huge fan. I don't give patients samples unless it's like they're in the donut hole, they ran out early, or they're bridging to a dose that's out of stock, and I'm going to use it to help them get to that dose. We're talking temporary supply, okay? Mass shortages are happening and will continue because all these medications are made by 2 drug companies, right? Novo and Lilly. So all these medications are competing within the same company in the same plants for production. So even in the last couple weeks, things have gotten worse. Wegovy, the lowest doses, the 0.25, 0.5, and 1 have been impossible to find, but apparently that's ramping up in the next few weeks and will be better. So now I'm going back to Wegovy. I haven't prescribed Wegovy for 6 months, no new starts at least. Saxenda, so liraglutide is going generic this summer, and everyone thinks it's going to be so cheap. But I don't, because that happened with insulin, right? Insulin was really expensive, and a few years ago, they came out with generics, right? Generic Glargine, generic Lispro, all these generics. Are they $25 like MPHs? No. They're like $500 a month instead of $700 a month, because why would the insurance company do any less when they don't have to, right? It's horrible. So I don't know what's going to happen with liraglutide, but I don't think they're going to keep making Saxenda, especially now that Novo has such heavy hitters with greater weight loss than Saxenda. Certain doses are out of stock, like Mounjaro. There are 6 doses of Mounjaro that you need to go through to get to the maximum dose. And with all of these pharmacy shortages, it's almost impossible to find the dose that you need and to continue on that medication dose. And if you have more than 1 missed dose, so 2 weeks of interruption in these medications, your body loses its acclimation and will have more side effects when you restart. You're supposed to restart at a lower dose. You're supposed to start over. So you can't do that with Wegovy. It's completely out of stock in the low doses. So you're kind of screwed. And if a patient can't tolerate the highest doses of Wegovy, the only 2 that are approved for maintenance of weight loss are 1.7 and 2.4. And if you have someone vomiting on 1.7, but you can't find the 1 milligram or their insurance won't cover it for maintenance, what are you going to do, right? And it's this auto-injector. They can't adjust the dose like they can with Ozempic semaglutide. So you're stuck. Pull the needle out halfway through and just hope that, I don't know, you don't get it all over your clothes. I don't know. It's really difficult. Mounjaro, I can't find any Mounjaro right now. None of it. No doses anywhere. And the rep is like, oh, try this pharmacy. And that day, I send it to that pharmacy. And I tell the patient, this rep tells me you can get it from this pharmacy and they'll deliver it to your house. No, they don't have it. Oh, we just ran out. We only have the 10 milligram. Can you give me the 10 milligram? Well, no, you can't jump up 3 doses of this medication and feel well. So it's difficult. Weight loss medications, weight loss has been considered a cosmetic thing in this country for years. It has not been considered a medical thing, and insurance has followed that. Medicare didn't even recognize obesity as a disease until the last 10 or 15 years. They just started 10 or 15 years ago. Once it was recognized as a disease, Medicare started covering bariatric surgery. Once they started covering bariatric surgery, everyone started covering it. So now it's really easy to get bariatric surgery, but really hard to get weight loss medications. A lot of employers have to opt in. The default is no weight loss medication coverage. Certain employers have to opt in. So I now have a list of 100 employers, and I ask the patient, oh, I'm insured through my husband. Where does your husband work? Bank of America. Oh, that's good. That's great. They're like, why do you care where my husband works? And then I have to be like, I'm sorry, I'm so nosy. But this is why it's important. Federal access has improved, which is good. So a lot of federal employees are able to get this now. TRICARE, even some state insurances, Medi-Cal in the state of California, which is our Medicaid program, actually covers these weight loss medications. Remember to always titrate gradually. Pay attention to your order set. You can try to help patients advocate for themselves. They're lobbying, they're going to Washington to try and advocate for Medicare to cover it because a lot of things start with Medicare and then trickle down to other insurance companies. Get involved, have patients get involved. They can contact their HR if they feel comfortable to try to get them to cover weight loss medications. I have tried. At Scripps, I have emailed every top person that I can think of who might have any weight in this decision, and they're just they're shutting us down. Our Scripps HMO plan doesn't cover weight loss medications, and they're saying the premiums would go up so dramatically for participants just to enable them to have coverage for these medications. So there's a lot of levels where there are problems here. I do not recommend compounded semaglutide. I know like an hour ago you might have heard differently, right? But if it comes in a vial, if it's pink or yellow or unlabeled with little stickers put on from some med spa, it's not branded semaglutide, and nobody really knows what's in it, especially the online programs. There's all this like counterfeit, fake stuff. People have had side effects. People have been hospitalized. If you read some of these news articles, it's not FDA approved. In fact, the FDA has warned online vendors. The drug companies have tried to go after compounding pharmacies, but they haven't won, at least not yet. The only reason they're allowed to do compounding is because these medications are on a shortage list. But overall, it's in Novo and Lilly's best interest to ramp up the production, which they are doing. They've acquired all these facilities, but by the time they do inspection and approval, it takes so long to start making medication. It will hopefully go off of the list and the compounding will stop. What I don't like about compounded medications, even if you get it from a reputable compounding pharmacy, what does that mean, right? What do we really know about it? Unless they did some really good trial data, or Novo said, yes, it's a copy, it's a generic molecule, which is not currently available, we don't know what's in it. From a medical legal standpoint, that makes me nervous. But what also bothers me is that they're expensive. They're not cheap. They're getting it cheap and selling it at an upcharge, which to me is taking advantage of a vulnerable population that already has suffered from this stigmatization and discrimination and really should be provided access to FDA-approved medication just like someone with high blood pressure or diabetes, okay? That's how I feel. Let's talk about surgery. We talked a little bit about this yesterday, but we're going to talk about it again, not in the context of diabetes. Hands down, bariatric surgery is still the strongest tool that we have for the most amount of weight loss and the most amount of weight kept off. Everyone keeps saying these medications are replacing bariatric surgery, and my hope is that maybe one day that is the case. But I don't quite think that that is where we are right now. And to be honest, I'm going to tell this story. I wasn't planning on telling it. But next month, I am speaking at a conference, ACE, so it's a national endocrinology conference. They asked me to speak in a debate. And I am debating a bariatric surgeon who was one of the authors of that Stampede trial I told you about yesterday, where they used bariatric surgery to treat diabetes and metabolic disease. And I was like, I don't want to do that. I couldn't say no. They're like going to pay for me to go, and it's in New Orleans. And it's wonderful, and I love going to these conferences, but it's like, so I had to come up, I was like digging deep, because right now the efficacy, the reduction in comorbid conditions is still far superior in bariatric surgery, unfortunately, right? Like, it would be nice not to need a surgical option for something that is a metabolic disease. But right now, I had to update this slide. It used to be a BMI above 35 with comorbid condition or above 40, regardless of medical conditions, is what qualified you. And that's what Medicare still has. However, ASMBS, the American Society for Metabolic and Bariatric Surgery, they added metabolic, because remember, bariatric surgery is no longer just a weight loss surgery. They have recommended in the past few years going down to a lower BMI. In fact, the ADA, because of that Stampede trial, is saying that in some people, the Stampede trial actually used people with lower BMIs than would have otherwise qualified for bariatric surgery, even 27.5 of Asian background with diabetes, which seems insane, but the more we're understanding about these medical conditions and how they improve with weight loss, the more that they are advocating for considering it at a lower BMI. So some insurance companies, including the Scripps HMO, which will not cover a single weight loss agent, have adopted these lower criteria to promote weight loss surgery because from a financial standpoint, long-term, surgery is still better bang for your buck. So what's out there? There's a gastric sleeve, there's a gastric bypass, there are a couple other surgeries, a SADI, and a duodenal switch. Lap band, which we're not doing anymore. It kind of defeated the purpose of bariatric surgery because the whole stomach was still there, but you just couldn't eat as much, so it was restrictive. But it didn't affect the GLP so much. It didn't affect ghrelin quite as much. And it ended up shifting, ulcerating. There's a GI doctor here who probably knows way more than I do about this, but 40% of them ended up needing to be removed. People had lots of dysphagia issues, just not good. We don't do them anymore. There's endoscopic procedures, so you can put in gastric balloons. The last I heard, they're only FDA approved for 6 months use at a time. Is that still correct? 6 months? So they were only approved for 6 months use at a time. What have we learned about obesity? You can't do anything for 6 months, take it out, and expect to maintain your weight loss, right? So why? People are like, well, maybe to prepare them for a surgery. Great, so they get a knee replacement, remove the tool that helped them get that knee replacement, and then rapidly regain the weight. That doesn't seem good either, right? And then there's this endoscopic sleeve gastroplasty, which I am not a huge fan of. I've had a couple patients get it done with our GI department. If you qualify for weight loss surgery, I would just have real weight loss surgery. In fact, I much prefer a gastric bypass over a gastric sleeve because of the efficacy, and this is less effective than a gastric sleeve. Reduction of comorbid conditions is unsurpassed in patients who have bariatric surgery. So the reduction in cardiovascular disease, high blood pressure, incontinence, fatty liver is amazing. I spoke at a Scripps heart failure conference a year or two ago, and the speaker before me was a bariatric surgeon who presented all his data on cardiovascular disease and the benefits of bariatric surgery. And it was amazing, and things that we might not be aware of and maybe should learn more about. The Swedish study that has been talked about before, which is nice because they have like a national registry in their healthcare system, has looked at 4,000 patients, not obese subjects, subjects with obesity, my bad, and what has happened over time. So here's the control group. This is gastric banding. This is a gastroplasty, so not a sleeve, but a sleeve gastroplasty endoscopic, and a gastric bypass. And you can see, yes, they reach a nadir in their weight loss at the 1 to 2 year mark, so 12 to 18 months, people do really well after surgery. And then they also have metabolic adaptation that can promote weight regain, and you might need to reintervene. But you can see 15 years down the road, the percent of weight loss that continues to be maintained with gastric bypass is over 20%. Patients always have, I call it the cousin and colleague phenomenon. I come up with names for everything, I don't know why. But the cousin and colleague phenomenon. Everyone has a cousin or a colleague who had bariatric surgery and failed, either regained all the weight or almost died. But I'm telling you, for every story of a patient like this, there are 10 patients who did amazingly well, who are walking around and people don't even know that they had bariatric surgery, okay? And most importantly, mortality. So you can see even just 5 years, the control group was more likely to be not alive than the patients that had surgery. And I think most patients don't want to be not alive. So don't rule it out just because it's invasive. So maintenance of weight loss, remember, even maintaining 5 to 10% has health benefits. Take immediate measures to counteract a plateau or regain, because that's where you end up really screwed. You lose weight, you regain it, and you do the same dietary plan and don't get the same results, and it's really frustrating. Consider referring to a weight maintenance program. Work on increasing exercise, lowering calories, forms of intermittent fasting we talked about yesterday. Consider adding a weight loss medication even for maintenance of weight loss, referring to a dietitian or a weight management center. The National Weight Control Registry has this website that literally looks like it was made in the 1980s. But you can go there and look at what data they have. So basically, they're collecting data from the nation, looking at patients who have successfully lost at least 30 pounds of their body weight and kept it off for at least a year. And they have some participants who've lost hundreds of pounds and kept it off for 20, 30 years. They track them over time using questionnaires and surveys. And the goal is to try to understand why some people are successful in losing weight and why some aren't. So they did find 78% eat breakfast every day, right? We talked about intermittent fasting yesterday. Intentionally skipping breakfast might be healthy as a form of intermittent fasting if you are eating healthy in the eating hours, but most people who skip breakfast then overeat later and have highly processed foods. 75% weigh themselves at least once a week, if not daily. Some people find it distressing to know their weight, or they have a history of eating disorder like anorexia, and in those patients, I will say don't weigh yourself, maybe use an article of clothing, or even like abdominal measurements, because that doesn't mean as much to people as a body weight, like 40 inches versus 36, like they don't really know the difference. They're not stigmatized yet, you know? They don't watch as much TV, and 90% of them are exercising on average about 1 hour per day, most commonly walking, but we talked about weight-bearing activity. If you are a successful loser, you can join the study, and there's a button you can click on to register. So don't be afraid to talk about weight with patients. Dedicate visits to weight management if you need to, because it is time intensive. Set realistic goals, look at their existing medication, use all the tools available to you, and focus on whatever has been accomplished, no matter how small, because patients are scared to come see us, especially when they're not losing weight. ACE has this journey for patients with obesity handout that I thought was kind of nice. It's on their website, and it kind of talks about all the different things you can do in the different stages of obesity and the different treatment options. So use as many as necessary. And this is the same slide I use for diabetes. But really, managing obesity looks easy, right? Eat less, move more. But it's not. It is so much more complicated than that because our bodies are smarter than willpower and smarter than our reflexes, and it's really hard to overcome. But it's exciting. There's a lot of new stuff coming out, and I'm excited to see what the future holds. So thank you.